my topic as practical tips in glass prescription. I will thinking that first year PGs and the other PGs are the main audience. I would limit myself to essential practical tips. So this is what I have told earlier. So you have heard retinoscopy, you have heard subjective refraction, and you have seen how a subjective refraction value is arrived at. So Natasha has already told you, measuring the retinoscopy is one thing, and many a time the prescription may not be synonymous with the retinoscopy value, because that's why subjective refraction we have, and the subjective refraction is very much influenced by the age of the patient, type of the patient, whether the patient has got a squint or not, whether the patient was having a previous spectacle correction. Then this subjective correction will be depending upon not only his retinoscopy value, but on his previous spectacle, nature of his profession, whether he works for near, whether he works at an intermediate distance. So all these things influence the prescription. So our aim for glass prescription should be comfortable vision for the patient and not accurate vision, because many a time theoretically correct accurate vision may not be the comfortable vision that the patient may be demanding. So you have done the subjective refraction and you have arrived at a prescription and you have handed over the prescription to the patient. And many a time, in 90-95% of cases, that may be the end of the matter. Patient is happy, you are happy. But at least in 5% of situations, handing over the prescription may be beginning of a problem. So what can be the problems? One thing is cosmetic, because nowadays cosmesis is very, very important. You are given a glass prescription to a patient. Probably you might have or you might not have told anything regarding the frame. So cosmesis may be a problem that also has to be taken care of. But comes to the real problems as you have done the subjective refraction and you are writing a prescription. So if you are very busy or you might have been at that point of time a bit absent-minded, your prescription may be wrong. So the patient comes back to the spectacle saying that, doctor, this is not suiting me. Or maybe you have given the right prescription and the optician may have dispensed something slightly different. So that's a problem. And another situation is you have done a good retinoscopy, you have done a good subjective refraction, and you have given a right prescription. But the patient is unable to adapt to that accurate refractive correction that you have given. So this happens mainly in high refractive areas. Patient is using glasses for the first time, or there was a significant difference between the previous prescription and the present prescription, and maybe a change in the cylindrical axis. So in all these situations, inability to adapt to an accurate refractive correction, many a time it comes because of inadequate patient education. So you should inform the patient that with this glass, you may experience these problems. So even if you are given the right prescription, sometimes the patient may be unable to adapt to it. So this can be taken care of either by asking the patient to wait for some time, he will get adapted to it. So there may be a few situations where you may have to change whatever you have given, even though you have given a right prescription. So in children, especially when you are giving glasses for the first time, or still they are complaining, always in children take a very good history and a thorough examination of the anterior segment as well as the posterior segment before giving a spectacular correction. See if there is any problem in the anterior segment and posterior segment which produces a defective vision. And in this context, I would like to tell all the PGs that read the developmental aspects of refraction. See, you should read what is the refractive status of an neonate at birth, what it is like, what the refractive status is like at 6 months, at 1 year, at 2 to 3 years, what happens into adulthood. And you should know what is happening in the cornea, what is happening in the lens, what is happening to the anterior posterior diameter of the globe over a period of time. So if you know that, you will be, because knowing this is very, very important in knowing ophthalmology as well as prescribing glasses in children as well as when you have cases like congenital cataract. So what is the type of intraocular lens that you are going to place? All this depends upon the developmental aspects. And in this context, I appeal to all the PGs to see what is happening from the neonate to adulthood in the development of the globe. That's very, very important. And in children, you may be tempted to do an autorefractometry and give the class for glasses for easiness sake. But retinoscopy is very, very important in children. So you may not be doing it in all visits, but retinoscopy is very important in children, especially for a first class prescription. And we said we refined the subjective refraction, but in many cases, in too young a child, you may have to depend on your retinoscopy alone, and based on the clinical situation, you will have to give this, and you cannot do too much of a subjective refraction in a too young a child. And so this is what Nadasha had told. If you, when you prescribe glasses for a myope, you give the minimum negative power, which gives the maximum visual acuity. So if you see, if you detect a congenital myopia in an infant, if you detect a myopia of even up to -4 diopters, it may be left alone, because depending upon the infant's needs, even 4 diopter of myopia can be left alone, and you need to correct it only at a slightly older age. And if the child is 1 or 2 years when you detect a myopia, -4 diopters and above may need correction. And if the child is 2 to 3 years, even -3 diopter and above may need to be corrected. But school going and above that age group, full correction of myopia, minimum negative power, including any cylindrical accretion if any has to be given. So in myopia, generally do not overcorrect. So these powers are these are general principles. There will be very rare situations when you may deviate from this, but this is the general principle in myopes. And if you look at hypermetropia in infants, on a cursory routine examination, if you find that the infant has gotten +6 diopter of or +6 diopter of hypermetropia, if there is no manifest squint, this hypermetropia need not be corrected. You can evaluate the child later. At 1 to 2 years, if more than 6 diopters, you may have to correct. If it is 2 to 3 years, even more than +4 diopters, you may have to correct. School going and above, even if the child has got a +1 diopter or above, if that addition of that plus correction improves the distant vision, you may have to give that correction. So that is the general principles regarding an hypermetropic correction. And regarding astigmatism, then again, in infants, even if you detect an astigmatism of up to 3 diopters, it may be left uncorrected. But it is 1 to 2 years, if more than 2.5 diopters, you correct. And 2 to 3 years, if more than 2 diopters, you correct. But in children, you should do a very good retinoscopy, and you should doubly make sure that your prescription and is correct before handing over the prescription to the child's parents. Very insignificant astigmatism like 0.25 or 0.5 diopter cylinder, if you detect in very young children, it may be left uncorrected, and you may need to follow up only after 1 year. And if you are giving an spherical correction to any child for any matter, depending upon the powers that is needed, anyway, if you are giving a spherical correction, any astigmatic correction associated may also be corrected. So earlier we are talking something regarding the frames. So if you are giving a glass prescription for a myope, especially myopes say -4 diopter and above, if you look at the eyes through this myopic glass, the eyes will look smaller. So if you give a big frame, what happens is the eyes will look comparatively even much smaller through a bigger frame with this myopic glass. So in myopes, generally smaller frames are preferred for cosmesis. And the converse is true in hypermetropia. So you can give small advices to the patients or your children's parents regarding the selection of frames in this context. And another difficult group to manage would be the toddlers. And in toddlers, what you have to bear in mind is that it should be a very good frame fit with a good optician. And usually, when we take dresses for toddlers, we we take dresses which are slightly larger so that it can fit them even after 6 months or 1 year. But when you look at spectacles, frames, and its fit, the frame size and fit should be ideal for now and not larger for maybe 6 months or 1 year later. We find that in children, when you give them the right correction, most of the children, you will be surprised to see children wearing very high cylinders if you are given the right correction, very happy. Many a time in children, we find that the initial resistance comes from the parents and grandparents, and they should be motivated regarding the glass usage by the children, and you should teach them the importance of the glass prescription depending upon the refractive status of the child. And when you prescribe bifocals, you should make sure that both the segments, the distant vision segment and the near vision segment, provide equally clear vision. And the level of the near vision segment shouldn't be hindering with the distant vision component. And there are various types of near vision segments like fused crypto bifocals, D-shaped bifocals, executive bifocals, like that. So depending upon the professional needs and the patient's personal needs, you may choose the near vision segment. And progressive lens, you make sure that in place of monofocals and bifocals, even if there is a bit of problem with the fitting, it may not be too much manifest for the patient. But progressive lens, unless the fit is ideal, they come back to you complaining. So it should be an ideal fit with a good optician. And patients who are changing from monofocals to progressive or from bifocals to progressive, tell them that these are the problems you will be having in the initial days, which you will get over. Problems in lens fitting is something which the optician has to take care of, but you should also be knowing what is happening here, because whenever a glass is fitted, we should measure the IPD, and the IPD will be marked on the dummy glasses in the frame which you have selected. And if it's a monofocal, it's only the IPD for distance. If it's a bifocal or progressive, IPD for distance as well as 1 year should be measured and should be marked, and the fit should be ideal to prevent problems. So in this context, I would like to say one more thing in this slide is something called an effective power of the lens. Effective power of the lens means like the effective power of an plus lens increases as it is brought anteriorly. Anteriorly means to the front. Similarly, the effective power of an minus lens increases as it is brought closer to the eye. So I will tell a small example. Suppose child was, you had given an 10-year-old child a -4 diopter last year, and now the power has increased to 4.5 or 4.75, and the child finds that he or she is difficult to read the blackboard from the back bench. What the child will do is, the child will press the glass against his or her eyes, and he will see a bit more clearly, because the effective power of a minus lens increases as it is brought closer to the eye. Similarly, a 55-year-old man with some hypermetropia and presbyopia, if he is using a +3 power for near vision, if he had been using it for the last 2-3 years, he may find that the near vision is slightly difficult. Small print is slightly difficult. He finds that with his present glass, if he brings it slightly anteriorly, it becomes more effective. So if you know the effective power of a lens, if the patient complains in this way, you can say that the patient needs a different power in his present refractive state. So frame selection, it's ultimately a patient's choice, but you can guide him in certain ways. So wrong prescription, I told you, is something which is rather unpardonable. So it may be an incorrect prescription, or it may be an illegible prescription. So if it's not legible, no, then again it's equivalent to giving an incorrect prescription. So, and what happens usually is you may mess up with the plus and minus signs, or maybe the axis you light like 10 degree and the optician gives 100 degree. So those problems happen. So glass prescription, when you write, make sure that the plus minus signs are correct and the axis is written very legibly, and there should be no mistakes in that. So with high refractive powers, you may have peripheral distortions. You may have to explain to the patient, and high index glasses which are available now takes care of most of the peripheral distortions and the restricted field. If a patient comes to you with frequent change of spectacles, rule out these things. Rule out diabetes, rule out glaucoma, rule out cataract, or rule out any other post-second pathology which is causing the defective vision. So when not to prescribe or not to change a lens. So very small refractive errors, asymptomatic, which is detected on a cursory examination, you need not prescribe, you can review later. The small changes in power which the a person is presently using, if it's asymptomatic and if it's a small change, do not change. And changing the axis of the cylinder, we be very careful, because a person who is wearing a cylinder at minus 80 degree, for the after the 2-3 years, if he wants a change in glass due to wear and tear of his spectacle frames, if you find that now his the 6/6 partial vision is 6/6 with minus 70 degree, if you change 80 to 70, almost sure the patient will come back saying that I'm having a problem. So change the axis of cylinder if the patient is asymptomatic and if is happy with the present power and access. Do not change if it necessarily warrants. That is another thing. And do not increase too much power in one step if it is not warranted. So the NOMS first do a monocular subjective refraction and finish with binocular viewing. Always remember, patient comfort is the most important factor, not the accurate vision, but the patient comfort is the most important factor. And always 6/6 vision with glass doesn't mean good vision. Patient may be happy with 6/10 with his previous glass if your prescription the patient is not tolerant about due to other reasons. So it's not 6/6 vision that we aim to give to the patient. We plan to give with your present glass good vision with which the patient is comfortable. Thank you.